Okay dah. Assalamualaikum and good afternoon. So today we will have Akhmal continue our presentation, our RACME on upper limb blocks, and today he will be talking about the infraclavicular and axillary brachial plexus blocks. So without further ado,
Right. Assalamualaikum and a very good evening to audience. So today I will present regarding about the upper limb block, which is more specifically in infraclavicular and axillary block. So before that, I will talk about overview of the brachial plexus. The brachial plexus, which is from the C5 to T1, supply most of the sensory and motor innervations of the upper limb. Exception, cutaneous supply of the proximal shoulder by the supraclavicular nerve, which is C3 and C4. Cutaneous supply of the medial aspect of the arm by the intercostobrachial nerve, which is T2. So basically, the brachial plexus will be divided into roots, trunk, division, and cord. Cord and lastly is terminal branches. So for the infraclavicular and the axillary, we will mainly talk about at the area of the cord and terminal branches. So this is the simplified of the brachial plexus, which consists of root, C5, C6, C7, C8, and T1. Trunk will be divided into the superior, middle, and inferior. Division, we have the anterior and posterior. Cord will have the lateral, posterior, and medial. Branches, we will have the musculocutaneous nerve, axillary nerve, median nerve, radial nerve, and ulnar nerve. So we go to the infraclavicular block. So basically, the indication for the infraclavicular block mainly for the anesthesia of analgesia or arm, elbow, forearm, and hand. So basically, the infraclavicular block, which is block of the brachial plexus at the level of the infraclavicular fossa deep to the pectoralis muscle. So basically, the infraclavicular space have the boundaries, which is the pectoralis major and minor will be anteriorly, serratus anterior muscle and rib will be medially, clavicle and coracoid process will be superiorly, and humerus on a lateral side. So at the level of the cord, we will have the medial cord, lateral cord, and posterior cord of the brachial plexus are arranged around the axillary artery, which is deep to the pectoralis major and minor muscle. So the rib and the pleura are deeper and medial to the cord of the brachial plexus. As you can see in the picture, the lateral cord, posterior cord, and medial cord is around the axillary artery. So patient and the probe position, patient will be lying in the supine with the head turned away from the side to be blocked. Abduction of the arm to the 90 degrees help brings the brachial plexus more superficially and elbow will be flexed. So the probe will be placed in a sagittal orientation over the lateral infraclavicular fossa below the clavicle and just medial to the coracoid process. So the coracoid process is the important landmark that can be easily identified by palpating the bony prominence just medial to the shoulder while the arm is elevated and low. So as you can see in the picture, the patient will be in the supine, the head will be turned contralateral to the side that wants to block, the arm is flexed 90 degree. So the probe will be in a sagittal orientation. So basically, this is the sonoanatomy that we can see. The above one, we will have the pectoralis major muscle, and then we have the pectoralis minor muscle. Then we have the axillary artery and axillary vein. Axillary vein will be located caudal to the axillary artery, which surrounding the axillary artery will have the posterior cord, lateral cord, and medial cord. Also in this picture, we also can have the serratus anterior muscle, and the white one, the below one on the right side is the pleura. So as I can see, The axillary artery is underneath the fascia of the pectoralis minor muscle. Then the axillary vein is seen as a compressible hypoechoic structure which is caudal to the artery. Cord of the brachial plexus is seen, which is the middle cord, will have the caudal from the axillary artery. Lateral cord will have the cranial to the axillary artery, and the posterior cord will be located deep to the axillary artery. Okay, so basically, if you want to do the infraclavicular block, we have the equipment such as the high frequency linear probe, short bevel block needle, 21 to 22 gauge with the length of 80 to 100 millimeter. For the local anesthetic volume, we have 20 to 30 mils, and then the anesthetic concentration can be a ropivacaine 0.3 to 0.5% or levobupivacaine 0.25 to 0.5%. So as a needle approach, we have implant cephalate to caudal direction to pass through the pectoralis major and minor, which our aim is toward the posterior aspect of the axillary artery. So our goal is to give a local anesthetic spread around the axillary artery or around the individual cords of the brachial plexus. Can have a single injection or multiple injection. All right. So we have some video.
In this live demonstration on a patient, the ultrasound is oriented first in the costoclavicular space. The lateral, posterior, and medial cords are visualized. As the transducer transitions from the costoclavicular space to coracoid process, the posterior and medial cords are seen rotating to their final position. We'll now demonstrate the classic approach to blocking the brachial plexus in the infraclavicular space. Here, the ultrasound transducer is oriented in the parasagittal plane medial to the coracoid process. The axillary artery can be identified deep to the pectoralis major and minor muscles. The axillary vein is also seen as a hypoechoic structure that lies medially to the axillary artery. With the left side of the screen corresponding to the cephalad aspect, the cords can often be seen as round hyperechoic structures. Again, these are named for their usual position relative to the axillary artery, although there is a great deal of anatomical variation. The lateral cord is usually located at 9 to 11 o'clock relative to the artery and is most cephalad. The posterior cord is usually at 5 to 7 o'clock posterior to the artery. And the medial cord is usually at 3 to 5 o'clock and is most caudate. As discussed earlier, the lateral cord may be in a distinct fascial compartment, a fascial compartment that contains the medial and posterior cords. In this demonstration, the needle is inserted first to approach the lateral cord. Approximately 5 to 10 cc's of local anesthetic is injected here. The needle is then advanced inferior to the axillary artery, closer to the fascial compartment containing the medial and posterior cords. A subtle pop may be elicited as you enter the fascial compartment. Approximately 20 cc's of local anesthetic is then injected here. The distinct medial and posterior cords are now seen more clearly. Additional injections around the lateral cord and medial and posterior cords are performed in this demonstration, but may not always be necessary.
Another one.
Okay, so here we see the axillary artery underneath the pec minor muscle. We can appreciate what looks like the lateral cord on the cephalad side. The needle passes through the pec major and pec minor muscles, and hydrodissection lifts the pec fascia off the artery. We want to scrape the paint off the artery, passing very close to it tangentially while we continue to hydrodissect. There, the needle tip is deep to the artery and we get immediate flow after passing through that fascial layer. Our aim is to see local anesthetic directly underneath the artery with no intervening structure.
Alright, so basically that's a video that we showed. So basically the infraclavicular block we have some contraindications and complications. So for the contraindication, basically is patient refusal or inability to cooperate, may have a skin infection at the block site, which have the severe coagulopathy and pre-existing active neurological deficit. So the complication that can be seen, such as vascular injury, hematoma, infection, local anesthetic toxicity, pneumothorax, and also hemidiaphragmatic paresis. Then we move on to the axillary blocks. So for axillary block, basically we will target it at the terminal branches from the brachial plexus. So an indication of the axillary block, which is anesthesia or analgesia for elbow, forearm, and hand. So basically, the transducer position, we have the short axis to arm, just distal to the pectoralis major incision. So the probe orientation will be anterior posterior. So first we need to identify the axillary artery on the medial aspect of the arm, which is 1 to 3 centimeter below the skin. Also can be seen one or more axillary vein which have the posterior to the axillary artery. Pressure will apply while scanning may compress the axillary veins. The nerve around the axillary artery will seen, which is median nerve, which is located anterior to the axillary artery, ulnar nerve located posterior to the axillary artery, and then radial nerve will have deep to posterior axillary artery. And then we also can see the muscle around the neurovascular bundle, which is bicep, coracobrachialis, and also conjoint tendon of latissimus dorsi and teres major. The musculocutaneous nerve is located outside the neurovascular bundle between the bicep and coracobrachialis muscle. So, like I said before, the axillary vein is located posterior to the axillary artery. Then around the axillary artery, we'll have the anterior, which is the number 2, which is median nerve. Posterior to the axillary artery, which is ulnar nerve, the number 4. And then the number 5 will have the radial nerve, which is located deep posterior to the axillary artery. Then the number 8 will have the bicep, which is bicep brachialis. The number 10 we have a coracobrachialis muscle, and the number 9 which is the conjoint tendon. So this is the sonoanatomy that we can see. Okay, so basically if we want to do same like the infraclavicular, we need to have the high frequency linear probe, short bevel block needles, 21 to 22 gauge. The length will be 50 millimeter. The plane will be in plane anterior to posterior injection. The volume will have 15 to 20 mils of local anesthetic. So our goal is to give a local anesthetic spread around the axillary artery. And then nerve and vessel are positioned closely together in the neurovascular bundle. Advancements of needle may require hydrodissection with small amount of local anesthetic. So basically our aim for the axillary block is around the axillary artery. Usually we have 2 injection lah. The first we aim at the neuromuscular bundle. Our aim to have a block at around the axillary artery is to block the median nerve, ulnar nerve, and radial nerve. Then the second injection mainly for the musculocutaneous nerve, which is between the coracobrachialis muscle and bicep muscles. We have some video.
For nerves, we recommend depositing local anesthetic in 3 locations. First, we'll inject 10 mils deep to the artery next to the radial nerve. Then we'll come back, redirect, and place 10 mils of local superficial to the artery to anesthetize the median and ulnar nerves. It's often necessary to do some careful hydrodissection with saline or local to peel the nerves off the artery and keep them safe from needle trauma. Finally, we'll withdraw almost back to the skin and then redirect in a steep trajectory to place 5 mils on the fascia plane next to musculocutaneous. Okay, let's look at how this is done. We see the needle approaching deep to the artery. Some gentle hydrodissection with saline establishes the plane Lifting the artery off the conjoint tendon, we switch to local and deposit 10 mils there. Then we redirect and nudge the needle up to the artery below the median nerve. Some hydrodissection here lifts the nerve off the artery. We advance slightly to make sure the rope reaches the ulnar nerve with a total of 10 mils on top of the artery. And finally, we click into the fascial plane that holds the MC and the deposit the last 5 inches here.
All right. So basically, that's my presentation for today for axillary block and infraclavicular blocks. Any question from the audience?
Can we just go back to the, I think there was one slide. In this particular figure by Nysora, here they represent the cords as being so-called in one partial compartment. So, but can you just go back to the subsequent video? Okay. So, but if you look at the figure that is shown here, you see that the lateral cord is in one compartment, whereas the posterior and the medial cord are in one compartment. So this is basically something relatively new. So in the past, we thought that the we thought that the 3 cords were all together in one compartment, but subsequent studies have shown that actually the medial and the posterior cord, they actually lie together in one partial plane, one partial compartment, whereas the lateral cord is in a separate compartment. So that's why when you see the subsequent 2 videos, they actually do 2 injections. One into the compartment where both the posterior and the medial cord lies, and a separate injection into the compartment where the lateral cord lies. So this is something new. Can you just go back to the image, the static image of the infraclavicular?
Okay, so if you look at this particular view, the main reason why they show these 2 different views is because with subtle changes in the position of the probe, you get 2 different structures deep to the cords. So in one particular view, the one that's deep to the cord is the serratus anterior muscle. Actually, the white line is not the pleura over there. So the white line over there should be the rib line. Where areas with subtle shifts in the probe, suddenly the view that is deep to the cord is actually the pleura. So this means that when you want to do your infraclavicular block, you should try to optimize your view such that what is deep to the cord is the serratus anterior muscle and not the pleura, for obvious reasons. Because if you accidentally inject deep to the cord, then at least you have some safety margin as compared to the if you inject with the pleura deep to the cords. Okay, so just go back to the diagram on the axillary block that has the different views of the nerves. Okay, so basically this diagram just basically aims to show you that there's a lot of anatomical variation as regards to the orientation of the nerves. So that's why when you want to do an axillary nerve block, what is most important is to actually try to scan proximal and distal to appreciate the anatomy. And especially if you want to block the musculocutaneous nerve, then you should be able to try to scan from proximal to distal, because you will see the musculocutaneous nerve moving away from the terminal nerves. So the other reason why you want to see the nerve is because you want to plan. Because in the past, what was taught in terms of the technique of the axillary nerve block was just a single injection, just like the infraclavicular, so a single injection. But more and more studies have shown that a multiple injection technique is the best for an axillary nerve block. So when you want to do a multiple injection technique, obviously you will need to block at the three terminal nerves separately, and then block the MCN as the fourth injection. But of course, let's say if you want to do an operation of the hand and you don't need the biceps to be blocked, or you don't need the forearm to be blocked, then there's no indication to block the MCN. And once you are able to see the nerves, then you need to plan how you want to inject. So, like Akhmal has just mentioned, a general rule of thumb is that the median nerve is usually the most anterior, the ulnar nerve is the one posterior, whereas the radial nerve is deep and posterior. Another rule of thumb is that usually the radial nerve is the thickest terminal nerve that will be seen as compared to the other two nerves in the same partial compartment. Okay, any questions? Okay, actually this is a different, it's a full can of worms talking about where to deposit your LA. So what, because when you do studies on how blocks affect, how do you get a clinical effect of blocks? Actually, if you look at the studies when they experimented, you only need 1 ml of LA if you inject intramural. So, but that is not our aim. So our aim is to inject perineurally because it is safe and it is just as effective. But obviously, you need time and for the block to work. So we need to remember that at the end of the day, all blocks are perineural within a compartment. So let's say, like if you do an axillary nerve block, is within that axillary nerve complex compartment, and you get your LA there, and the LA will diffuse through the epidural, and a small amount will diffuse through the perineum and act on the nerve. Because you do not need the doses that we give. If you inject intranurally, is overkill. But the doses we give are the ones that is effective to allow the drug to diffuse and still have some amount of diffusion through the perineum, which is generally kind of like a blood-brain barrier of sorts. And that small amount that diffuses through is the one that exerts the clinical effect. But if you inject outside of the compartment, then obviously your block may not provide the efficacy. But of course, it's gonna be a case by case basis. Because even like for example, like when people wanted to look at the you call interscalene, like the interscalene block, people have demonstrated that you do not need to necessarily pierce the fascia that leads into the compartment to have a clinical effect. So you can just inject slightly lateral to the cause without necessarily piercing the fascia to get an intercostal interscalene nerve block. But let's say if you want to block something like the sciatic nerve, which is the thickest peripheral nerve in the body, and some of you may remember that I've mentioned that the sciatic nerve is actually not one nerve, it's actually two nerves in one. So it's actually the CPN and the tibial nerve in one paraneural nerve compartment. So if you inject outside of the paraneural compartment, which is also known as the blockages, then you may not get a desired effect. That is either in terms of whether it's the peak effect or whether it's the onset of the effect. You won't get it. And that's why in those kind of situations, it is advocated that you actually inject into the blockage, and that's how you get the separation. You will see the separation of the two nerves within the compartment. Another thing to consider is what is the aim of your block? Because if the aim of your block is pure, it's just analgesia rather than anesthesia, then if your LA can have is in the vicinity of the nerve, then it may still provide efficacy. But if you want to do an anesthetic block, then you may want to ensure that your needle is truly paraneural, but not intramural, but not intramural. But of course, the topic of intraneural injection and nerve injury is just a whole different topic, which I will present on in the MRAS next month. I think, okay, so the retroclavicular approach basically is not presented here. So the infraclavicular approach has basically three versions. Classical infraclavicular, we have the costoclavicular, which is not shown here, and also the retroclavicular, which is also not shown here. The main advantage of the retroclavicular, basically with the retroclavicular approach, you inject from the supraclavicular fossa beneath the clavicle and then into the infraclavicular region. And the main advantage of this technique is that your needle is in a perpendicular orientation to the ultrasound beam. So when it's perpendicular to the ultrasound beam, then you have good visualization of the needle as compared to a classical infraclavicular approach where the needle has to be steep. And because of that, you cannot really visualize the needle as well. That's the main advantage. Of course, the main disadvantage is what is the unknown. And the unknown is what is going on at the deep to the clavicle. So there's ongoing debate about that, specifically talking about the risk of supraspinatus. Or is it supraspinatus? Nerve injury. So basically, that is one of the unknowns. And some of the caliber studies have shown that sometimes you may accidentally hit the I think suprascapular. I can't remember. I need to recheck on that the particular nerve. I think it's suprascapular. So then you have the risk of nerve injury from that. What is the clinical significance? It has yet to be seen. Because at the end of the day, especially when talking about nerve injury in general, the incidence is extremely low, and therefore it's very difficult to make definitive statements. Because when the incidence is low, it's very difficult to make a study that is powered enough to show whether something is conclusive or not. So, but the caliber study does show that you may actually accidentally hit the nerve during the needle advancement. Suprascapular nerve. That one is the pain nerve. But at the moment, my go-to method, if I want to block the infraclavicular approach, is the costoclavicular. The main advantage of the costoclavicular, which I specifically did not ask to present, is that since they are the three costs are in actually one compartment, and therefore when they are in one compartment, you do not need multiple injections. So you only need to inject at one angle, and if you get good spread, then you can just deposit your LA. Similar to like a femoral nerve block. If you get good spread, you only need to do a single injection. You do not need to necessarily aim for a circumferential spread. Well, actually, okay, there are two things when you talk about vascular puncture with peripheral nerve blocks. Number one, it's difficult to puncture a vessel with a peripheral nerve block because of the needle designs that are used. So our hypodermic needles are all short bevel needles, which means they have a narrow angle. So when they have a narrow angle, they cut through tissue. So that's why when you, for example, when you insert an IV cannula, that's why your needle very readily goes through the soft tissue, and you feel a subtle give when you enter a vein. And there are many times, I'm pretty sure you have seen many times when you just try to fish out a vein, you do not feel anything until you suddenly see a flashback. That's because of the design of the hypodermic needles. Most block needles are not long bevel, but instead short bevel. So they have a steep angle. So when there's a steep angle to the bevel, then there is increased resistance to the tissue. and because of that, you are able to readily appreciate partial clicks. And that is also one reason why it's difficult to puncture vessels. The other thing is there are many people who advocate whenever you approach any kind of structure that you do not want to impale, then you should approach them in a tangential manner. So, for example, like let's say, like in this particular diagram, so the needle is approaching the 8 o'clock position of the axillary artery. So as compared to if let's say the needle approaches the 10 o'clock, 11 o'clock approach angle of the axillary artery, then you can have the risk of puncture. So it's a recommendation that you perform tangential approaches to structures. And this is actually not just regard to the vessel, but also regard to the nerves itself. So there have been studies showing that tangential approaches to nerves helps to reduce the risk of impaling the nerve, and therefore your needle remains in a paraneural position. So this is very useful. For example, like the sciatic nerve block, where you want to be careful to not when you want to enter the paraneural sheath and you want to avoid puncturing either the CPN or the TN, then you approach it in a tangential manner, and the structures actually roll away rather than being punctured. The other thing is when you talk about the axillary nerve block, the classical technique of the axillary nerve block is actually a transarterial technique, where it is an intentional arterial puncture. It's an intentional arterial puncture, and then you just do a single injection. And this was the technique before the advent of ultrasound in terms of peripheral nerve blocks.
So intentionally puncture, then we draw until we saw blood, we draw.
I mean, you puncture through and through.
True and true.
No. It's a through and through. Through and through the artery. So basically you're gonna deposit.
So macam itu macam anatomical lah.
You're going to deposit at the 6 o'clock position, deep to the artery, and then you depend on the whatever spread that's gonna happen and hit all the nerves. And then you may be thinking, how come there's no incidence of nerve injury? Actually, you may be surprised, but ultrasound does not reduce nerve injury. So the shift in blocks from nerve stimulator based to ultrasound based peripheral nerve blocks has not reduced the incidence of nerve injury. All it has done is improve the efficacy. So the dosages required have come down, and then the success rate has gone up, but the nerve injury rate has not come down. So you may be asking why. Okay, I've done my literature review, and that's in progress. But one thing you need to remember is that just because you hit the nerve doesn't mean you get injury. So there have been even some, you may argue, unethical studies where the authors intentionally inject intraneurally in volunteers, and they were not able to demonstrate nerve injury. So one of the positive reasons is that, number one, with peripheral nerves, we are not talking about the intercostal, with peripheral nerves, there's a higher amount of stromal tissue to nerve tissue. So when the needle goes, if the needle even actually goes into a nerve, then it is actually entering the soft tissue rather than the axon and myelin sheath, rather than the fascicles. And because of that, there's a reduced risk of nerve damage. That's the that's the main thing. But of course, nobody's gonna do the kind of experiment on the interscalene, because with the interscalene, that's why the interscalene you don't see it's just a black structure. But it's all nervous tissue with not much stromal tissue. And that's why when you talk about peripheral nerve blocks, one of the nerves with the highest rate of nerve injury is the interscalene, because of the proximity to the neuraxis. So the nerves have higher amounts of nerve tissue compared to stromal tissue, and therefore if you accidentally hit the nerve, juvenile injury as compared to all these peripheral nerves. I mean, you yourself in your practice, you've had patients with difficult IV lines. You try to insert a brachial vein cannula with much difficulty. You never actually look for the brachial nerve. You never look for the median nerve, which actually lies medial to the brachial vein. But somehow or other, patients come out without median nerve injury. Or you try to insert you try to insert IV cannulas into the distal forearm veins, or you try to insert a radial outline, and somehow or other your patients magically never develop terminal radial nerve injuries. What are the reason is because of the design of the nerves, they are much more difficult to injure.
Okay.
But it doesn't mean that you shouldn't have safety. Does not mean that you should not have safety. So even that paper where they intentionally inject internally, of course there's a lot of consternation among the academicians for the ethics of the study. But that study showed that all of the volunteers did not develop nerve injury despite intentional intraneural. So that's why it's very it's very difficult to have a true recommendation as to nerve block safety, because the incident is so low. So it's difficult for you to make a properly powered study. Any other questions? Okay. If there are no questions, then we'll take Akhmal in the usual manner. Thank you.